Good morning. Welcome to Raaonline. Today I'll be talking to you about regional anesthesia and cardiac surgery. Do they get along? Now, this talk would be around 30 minutes, and as I take you through this talk, I would be talking about how cardiac anesthesia started its love affair with opioids. We were a group of people who went very, very high on opioids, and then we had issues with using too much of opioids. It's like you compare a young couple who enter medical college, they fall in love in the first year of college. And then what do they go through their 5 years? How do they go through their love affair? And how do they come out of college? I'm going to equate this with my talk. So first I'd be talking about cardiac anesthesia's love affair with opioids. Then I talk about what the problem of pain in cardiac surgery is, basically the midlife crisis. Then I would be talking about how do you solve this midlife crisis of cardiac surgical pain. Then what are the strategies to prevent pain and reduce opioid use in cardiac surgery. So this plan should be preoperative, intraoperative and postoperative. Then the journey of regional anesthesia and cardiac surgery. What is the initiation? Then comes the best thing which has occurred to cardiac anesthesia of recent, the facial plane block. I'll talk to you about the rise of the good enough block, which is the execution part of this plan. Then I talk about the experience of the facial plane blocks. What is the data which is present as of now favoring the facial plane block? And I'll give you a small protocol which I'd like to use in my practice. Starting, as a perioperative physician, we anesthetists have an intense need to control intraoperative and postoperative pain. Till the early 90s, we cardiac anesthetists went on a high-dose narcotic strategy using long-acting agents. The only result was prolonged mechanical ventilation and ICU stay. Of course, opioids are the mainstay of pain relief in cardiac anesthesia as of now still. It is the principal means of analgesia for cardiac anesthesia. Why so? Because it produces satisfactory analgesia and sedation with a good amount of hemodynamic stability. And opioids are used right from your pre-medication process until you're discharged as far as cardiac surgery is concerned. The use of opioids is very high in the ICU to provide for post-operative analgesia. But with the world of ERAS and opioid-free anesthesia coming into play, cardiac anesthesia is definitely lagging behind in this particular aspect. With the heavy opioid dose approach which we usually use, what happens is we have a patient who is drowsy, has some amount of respiratory and cardiac depression, his extubation is delayed, he complains of urinary retention, nausea and postoperative pulmonary complications become a problem. And the looming opioid epidemic. This is widely described in Western literature, but it has not been discussed very much in our Indian literature. So what are the problems with opioid abuse? You would have increased morbidity, increased mortality, and addiction potential. The other problems of opioids are you can have ICU delirium, a delayed intestinal recovery, tolerance, hyperalgesia, and withdrawal. Then coming to the next part, you have a love affair, and then over a period of time, there is some amount of monotony setting into the relationship between two people. They come across a midlife crisis. Now, this midlife crisis is the same as what pain and cardiac surgery go through. They're quite inseparable. So what do we do about it? 3/4 of all our cardiac surgical patients have severe acute dynamic postoperative pain which persists even after 4 days of surgery. And I'm talking only about acute pain. Pain in cardiac surgery is due to vascular catheters, sternotomy, rib retraction and pericardiotomy, parietal pleural irritation, chest tubes, the saphenous vein harvesting site, the radial artery harvesting site, and musculoskeletal trauma from thoracotomy. Now, what happens with poorly controlled postoperative or intraoperative pain? You would have a restricted breathing and inability to cough, and you would have a prolonged intubation and ICU stay. You would also have an increased myocardial oxygen demand, which leads to increased oxygen consumption and hemodynamic instability, causing hypotension and tachycardia, and untreated pain leads to stress hormone release and sympathetic stimulation, all of which are unwarranted in cardiac surgery and cardiac anesthesia. So what is acute pain in cardiac surgery? It is the pain that occurs within the first 24 hours of surgery, and it is usually maximum in the incision sites. This pain is severe, usually occurs at deep breathing or coughing, or for some patients even at rest. And the post 24 hours, in the early recovery period, this pain starts shifting to the shoulders, back, and the saphenous vein harvesting site.